A very good morning to all. Today I am here with another topic that is cancer of the larynx or laryngeal cancer. Let me introduce the topic. Cancer of the larynx is a malignant tumor in and around the larynx. Cancer can develop in any part of the larynx but usually begins in the glottis. Most laryngeal cancers start in the flat scale like squamous cells that line inner walls of the larynx. So, laryngeal cancer or cancer of larynx is a one of the main malignant tumor which is occurring around the larynx or in the voice box, and it can develop any part of the larynx, but usually it is beginning with the glottis. Most laryngeal cancers start in flat scale like squamous cell. Okay, beginning of the cancer cell is squamous cell carcinoma. Then that will lining on the walls of the larynx. So this is about laryngeal cancer. Let us see the definition. Laryngeal cancer is a disease in which malignant cells form in the tissues of the larynx. So, like any other cancer definition, it is also a disease in which malignant cells or cancer cells forms in the tissues of the larynx or multiplication of abnormal cells in the larynx. Most laryngeal cells form in squamous cells, the thin flat cells lining the inside of the larynx. Laryngeal cancer is a type of head and neck cancer. So most of the laryngeal cancers are belongs to squamous cell cancer that lining the inside of the larynx, and this laryngeal cancer will belongs to the type of head and neck cancer. So laryngeal cancer is comes under head and neck cancer. Let us see the incidence. Cancer of the larynx occurs more frequently in men than in women. So the incidence ratio is more frequently in men than women, more commonly seen in men, four times higher in men. Then and it is most common in people between the ages of 50 to 70 years of age. Okay, most commonly you can seen in between the age 50 to 70 years. This account for half of all head and neck cancer. Half of the 50% of the head and neck cancer comes under laryngeal cancer. So this is all about the incidence. Let us see the causes and risk factors. In that causes for all cancer, the primary cause will be not clear or it is idiopathic. Okay, not defined. So the risk factors we will discuss that are gender, four times more common in men than women. Age is above 40, 65 to or older. Race means more common among African Americans and whites. Then poor diet. Poor diet is also a cause for laryngeal cancer, not only laryngeal cancer, nor other cancer, because nutrition deficiency, mainly vitamin B deficiency, that can lead to some form of abnormal cells in the body. Then family history, people who have a first degree relative diagnosed with the head and neck cancer have double the risk. So if anybody in the family is having laryngeal cancer or head and neck cancer, for them also there's a chance of getting laryngeal cancer. Then low immunity, like HIV or AIDS condition, because of the lower immunity, there or any organ transplantation also, some abnormal cell growth can occur. Then acid reflux, so GERD, okay, gastroesophageal reflux disease. Last year we have studied. So it can irritate and damage the larynx and may cause cancer risk. Okay, so if too much time the fluid is regurgitating, acid is coming to the larynx or is coming to the food pipe, it can lead to irritation of the mucosal lining and can lead to squamous cell carcinoma. Then tobacco, as you know already, we have discussed about the risk for tobacco and smoking. It can lead to infection and inflammation of the larynx, and thereby there is a risk of cancer. Then alcohol use, heavy drinkers, okay, so they are more prone for laryngeal cancer. Then human papilloma virus, HPV, so it is also linked with throat cancer. Then genetic syndromes, then like Fanconi anemia. Okay, this is a condition caused by inherited defect in several genes. Okay, it's a genetic condition, Fanconi anemia. That is also a risk for this laryngeal cancer. Then workplace exposure or industry occupational background, like those who are working long time and intense exposure to wood dust. Okay, those are working in wood mill and all, then paint fumes, especially wood mill and in plywood companies and all. Then those are working in paint, okay, paint fumes are there. Then chemicals, metal working, petroleum, plastic, and textile industry. In all areas, there are a lot of use of chemicals, so that can lead to irritation of the laryngeal wall. Then exposure to asbestos, that is also comes under workplace exposure. Then they are having more risk for lung cancer and mesothelioma. Then straining of voice, that is also a risk for laryngeal cancer, especially those who are in the occupation of singers, then cheer groups, okay, then commentary peoples. They are having their lot of voice they are using. They are straining their voice, so that can lead to laryngeal cancer. Then chronic laryngitis, if the laryngitis, if you are not treating properly, that can lead to laryngeal cancer. So these are the possible risk factors, and the primary cause is unknown. Then let us see the pathophysiology, short pathophysiology. So due to the etiological factor, here the etiological factors are risk factors. Progressive accumulation of genetic alteration in cells. Okay, so day by day, or cancer is not a acute condition. So day by day, the progression is occurring, and it can lead to alterations in the cells, certain changes happening in the cells and tissues. Transformation of squamous cells of larynx. Then once the cellular changes is happening, that can transform to squamous cells, carcinoma, mainly in the larynx. It will take 20 to 25 years period of latency after initial toxin exposure. That's why I told that it's a progressive accumulation. So once we are, if we are continuous exposure or continuous contact with this kind of etiological factors, it will take around 20 to 25 years to become cancer. And DNA damage and mutation of genes will happening. So this is all about the pathophysiology of laryngeal cancer. Let us see the signs and symptoms. Hoarseness or change in voice, like hot potato voice. Hot potato voice means you can experience that particular thing. So once after boiling the potato, if you are directly, if you are putting the potato in your mouth, so that time the maybe you will feel some kind of coldness over the potato, but inside the potato there is so too much hot will be there. So once you start biting, that time your that inner heat will be producing, and you can't able to spit and you can't able to swallow, like the situation. That is a kind of hoarseness. Then sore throat and ear pain, persistent cough or chest infections, difficulty in swallowing, dysphagia, painful swallowing, odinophagia, then a lump in the throat, shortness of breath. Okay, something is obstructed in the throat, like that you will feel. Then shortness of breath is bad breath or halitosis. Then weight loss will be there because of the abnormal cancer cells, prolonged earache, then cervical lymphadenopathy. So these are the possible signs and symptoms you can see in laryngeal cancer. Then how the diagnosis, how we can diagnose? Mainly history collection, collect the proper history about the risk factors. What all risk factors we have discussed, all the risk factors should be collected properly. Then physical examination should be done with the help of laryngoscope, with the help of laryngoscope we can do. Then oral examination, then palpation, okay, percussion. Then indirect laryngoscopy using endoscopy, and with the help of endoscopy. Then CT scan and MRI scan helps to evaluate the extension of the condition. PET scan, positron emission tomography, that helps to identify whether it's involved to the airway tract. Then bone scan, whether it is affected the cartilages or the neck bones. Then barium swallow, that is also helps to identify the extension of the disease. Then biopsy helps to identify the tumor cells. So these are the diagnosis for laryngeal cancer. Then next we will go for the stages. There are certain stages are there, mainly four stages are there, we will discuss. So first one, stage 0, that is called carcinoma in situ. Carcinoma in situ means in the original position. Abnormal cells are found in the lining of larynx. Stage O is called carcinoma in situ. So in stage O or stage 0, the abnormal cells we can see in the lining of larynx. Then stage 1, in stage 1 cancer was formed. Stage 1 laryngeal cancer depend on where cancer began in the larynx. Okay, so cancer is confirmed in stage 1, and it will depend on where it is began. So like a supraglottis, okay, then glottis and subglottis. There are the three areas where the cancer can begin. Then stage 2, in stage 2 cancer in the larynx only. Okay, stage 2 laryngeal cancer depend on where cancer began in the larynx. So in stage 2 also the cancer is remaining in the larynx only, like in supraglottis, then glottis and subglottis. In these areas, one or two more than one area will be affected, or surrounding tissue will be affected, but still the cancer in the larynx. Then stage 3, laryngeal cancer depend on whether cancer spread from the supraglottis, glottis and subglottis. I have told in the first stage, mainly it is affecting the three areas of the larynx, supraglottis, glottis and subglottis. So in stage 3, still stage 2, the cancer is in the larynx. Okay, it is surrounded or it is just spread in the larynx only. In the stage 3, the cancer spread beyond the larynx. Okay, means cancer is in the larynx only, and the vocal cords cannot move. Cancer may have spread to the one lymph node in the same side of the neck, so it starts spread to the adjacent lymph node of the neck. Then it may be from 3 centimeters away from the original tumor. So that is happening in stage 3. Then another thing, cancer is one or both, is in one or both vocal cords and in one lymph node. So it is already start spreading to the vocal cord and lymph node, then spread to the supraglottis, or vocal cords cannot move normally. Cancer has spread to one lymph node or the same side of the neck as the original tumor, and the lymph node is 3 centimeters or smaller. So that already we have discussed. So it already start to spread. Then stage 4 is divided into stage 4A, stage 4B, and stage 4C. So in this one, each substage is the same for cancer in the supraglottis, glottis, or subglottis. So in the first stage, I told that cancer in laryngeal cancer may occur in the glottis, supraglottis, and subglottis region. So these stages will be same for each region. Stage 4A means cancer has spread through the thyroid cartilage. Okay, from the supraglottis or glottis or subglottis, the cancer spread to the thyroid cartilage tissues beyond the larynx, such as neck, trachea, thyroid, or esophagus. So this many areas will be spreaded. The vocal cord may not be move normally. In this stage, the person can't able to move the vocal cord, so sound will not produce. Then stage 4B, in that cancer spread to the space in front of the spinal column, surrounds a carotid artery, or has spread to parts of the chest. So beyond the level of stage 4A, okay, in stage 4B, again it is spread to the spinal column. Okay, behind the neck portion, spinal column is there. It's spread to the spinal column. Then carotid artery, okay, one artery is going towards the brain. It is spread to the artery, and also parts of the chest. Cancer has spread to a lymph node that is larger than 6 centimeters. So in the stage A, 4A, you can see that lymph node is larger than 3 centimeters, but not larger than 6 centimeters. So the cancer formation is it is not more than 6 centimeter in stage 4A, but in stage 4B, it is more than or larger than 6 centimeter. And in stage 4C, cancer has spread to other part of the body, such as lung, liver, or bone. So in stage 4C, the malignancy is progressed and it is spread to the other part of the body like lungs, liver, or bone. Okay, so this is all about the stages of laryngeal cancer. Let us see the management. The standard treatment are radiation therapy, surgery, and chemotherapy. As we already know, and you have gone through the oncological conditions, you can see that the main treatment for this cancer is radiation therapy, chemotherapy, and surgery. And for laryngeal cancer, there is new type of treatment is a chemo prevention and radio sensitizers. So we will discuss. First one, radiation therapy. Radiation therapy is a cancer treatment that uses high energy X-rays or other type of radiation to kill cancer. So with the help of X-rays or gamma rays or infrared or ultraviolet rays, we are using this high wave or high energy rays to destroy the cancer cells. External radiation therapy uses a machine outside the body to send radiation toward the cancer. So external radiation, we are using a machine like a CT scan, like a machine we are using. With the help of the machine, we are directly exposure the rays to the affected area. And internal radiation therapy uses a radioactive substance sealed in needles, seeds, wires, or catheters that are placed directly into or near the cancer. So two type of radiation therapy you may study it is there. In that, internal and external is there. External means with the help of a machine we are directly focusing the light rays or high energy rays to the area where the cancer is affected. And internal radiation means with the help of needles, seeds, wires, or catheters. With these things we are making this is an invasive procedure. We are surgically we are placing in the area where the cancer is present. Then next one, chemotherapy use drugs to stop the growth of cells. So in chemotherapy, we are using chemicals or drugs to stop the cancer cells either by killing the cells or stopping the cell from dividing. So we are inhibiting the multiplication, or we are stopping the progression of the cell. Okay, so drug is 5-fluorouracil. So many drugs are there. Then surgical management, including vocal cord stripping. The first is surgical management in vocal cord stripping. It is used to treat dysplasia, hyperkeratosis, and leukoplakia. So that is one surgical management. Second one is cordectomy. So we are removing the vocal cord. So surgery to remove the vocal cords. So that is called cordectomy. Then supraglottic laryngectomy, in the surgery to remove the supraglottis only. So I have told that in the stages it can affect the glottis, supraglottis, and subglottis. If the laryngeal cancer is present in the supraglottis region, then we are going for removal of supraglottis. The surgery is called supraglottic laryngectomy. Then hemilaryngectomy. In that surgery to remove half of the larynx. That means half of the voice box is removing. A hemilaryngectomy saves the voice. So half of the larynx, if you are removing, means we can save the voice also. Then this is a procedure we are doing in the hemilaryngectomy. Half of the portion we are removing up to the level of the vocal cord. We will not remove the vocal cord. Then partial laryngectomy, in that surgery to remove parts of the larynx, okay, where the exactly the cancer cells are present, that particular area we are removing. Then total laryngectomy, surgery to remove the whole larynx. In this condition, the person will lose producing sound. Then thyroidectomy, the removal of all part of the thyroid. If the cancer cell is extend or spread to the thyroid gland, then we are removing the entire thyroid gland or parts of the thyroid gland. That is called thyroidectomy. Then another surgical treatment is laser surgery, a surgical procedure that uses a laser beam as a knife to make bloodless cut in tissues or to remove a surface lesion such as a tumor. So it is a less bleeded surgery or bleeded management. It's a bloodless cut we are made on the tissues to remove the lesions or tumor. Then next one is an new techniques like chemo prevention. Chemo prevention is the use of drugs, vitamins, or other substances to reduce the risk of developing cancer or to reduce the risk cancer will reoccur. So chemo prevention we are using. It is not here we are using some kind of drugs, vitamins, and other substances like supplement, nutrition supplement we are using to reduce the risk of developing cancer or to reduce the risk will reoccur. So it's a further management after the chemotherapy or radiation therapy or surgical therapy. We are using this chemo prevention in order to prevent the reoccurrence. The drug isotretinoin is being studied to prevent the development of second cancer in patients who have had cancer of the head or neck. So it is a medicine isotretinoin. The studies are going on, and it is proved that it will helps to prevent the reoccurrence of head and neck cancer. Then radiosensitizers are drugs that make tumor cells more sensitive to radiation therapy. Combining radiation therapy with radiosensitizers may kill more tumor cells. So radiosensitizers are the things which you are using or drugs which you are using along with radiation therapy. So this will helps to improve the effectiveness of radiation therapy. So combining radiation therapy with radiosensitizers will help for kill more tumor cells. So compared to chemotherapy, radiation therapy is more safe. So along with radiosensitizers, if you are doing radiation therapy, it will helps to kill the tumor cells. Let us see the complications: wound infection, skin breakdowns, pharyngocutaneous fistula. There is some formation of pharyngocutaneous fistula or a abnormal channel will be creating. Then carotid artery rupture, then tracheobronchitis, respiratory distress, hemorrhage, aspiration, and tracheostenial stenosis. So these are the possible complications which you can see in laryngeal cancer. Let us see the nursing management. First of all, pre-operative management. Assess knowledge and understanding of the diagnosis and proposed surgery. We have to assess the patient knowledge, understanding about the surgery and treatment. Clarify information and reinforce previous teaching as needed. If they need some education, that should be given, and you have to clarify their doubts. Assess anxiety levels of the client and family related to the diagnosis and proposed surgery. We have to inform their family members and also the patient about the surgery and all. Then point out the surgery will affect the sense of taste and smell and eating in the initial postoperative period, so that what are the possible adverse effects that we have to explain to them. Emphasize that total laryngeal will result in a loss of speech and that the client will breathe through a permanent stoma in the neck. So those who undergone a total laryngectomy, we are continuing the respiration with tracheostomy. So in condition, we have to explain the patient about the possible complication like loss of speech. So if total laryngectomy means the vocal cord also will lose, so they may go for a total loss of speech, and also there is a possible tracheostomy. Then establish a means of communicating postoperatively using a magic slate, alphabet board, eyes, or hand signals or other strategies. Those who are lost their speech or they are having difficulty in talk, for them we have to establish a means of communicating skills. Okay, like magic slate. Okay, with the help of slate, alphabet board, eyes for communicating. Reassure that nutrition and fluid needs will be met with intravenous or internal feeds until eating can be resumed. So they may be in nil per order. So you have to assure them about the nutrition and fluid needs. Then arrange a visit by a post laryngectomy client, means a group laryngectomy group people. We have to interact them with the people those who already undergone laryngectomy. It will help to improve their psychological status. Then do the routine lab test and get anesthetic opinion. Then overnight fasting enema should be given. So these are the pre-operative preparations. Let us see what are the post-operative management. The first one, airway and breathing should be managed. Ensure a stable airway within tracheostomy and oxygen. One or more drains may be present in the postoperative period. If the patient is able, allow him to cough. If the patient is not able to cough, suctioning by the stoma is necessary. So we have to manage the airway and breathing. So soon after the surgery, they may have two or three drainage tubes. So we have to take care of that one. And we have to continue their airway with tracheostomy and oxygen. And also we have to allow him to cough. If they are not able to cough, then we have to suction the secretion. Otherwise, there is a chance of aspiration. Take thin liquids by mouth. Encourage 6 to 8 glasses of fluids per day. We have to encourage them to take fluid 6 to 8 glasses of fluids, and we have to tell them to take liquid by mouth. Listen to lungs frequently assess for breathing sound changes that may indicate pneumonia or pulmonary infection. So we have to assess their chest auscultation should be done to identify whether any changes in the breathing sound or is there any chance of pulmonary infection. Then frequent position changes, then encouraging deep breathing and monitoring pulse oximetry. So identify the oxygen saturation. We have to encourage them for pulse for deep breathing and also monitor pulse oximetry. Let us see the nutrition supplements, what all things we have to provide. Generally, a nasogastric tube is inserted during laryngectomy. It usually remains in place for 7 to 10 days. The tube is used to remove gastric contents while intermittent suction for the first 24 to 48 hours post-operatively. So, a nasogastric tube will be placed in for the patient during the laryngectomy. It helps to remove the gastric content and also help for feeding. When bowel sounds are present, tube feedings are started slowly and advanced to meet the patient's nutritional needs. So proper feeding should be given, and we have to meet the patient nutritional needs. Daily weight and blood chemistries are obtained to monitor for any fluid or electrolyte imbalance, and replacement therapy is administered as indicated. We have to monitor their blood levels, okay, serum blood levels, whether any deficiency in electrolyte or any deficiency in glucose that will should be replaced with the replacement therapy. When patient's incision are healed with no evidence of fistula formation, the patient is advanced to an oral diet. Patient should have a high fiber diet to keep stool soft or use stool softness if necessary. So once the nasogastric tube is removed and the patient's incision area or the surgical area is healed properly without any abnormal channels, then we can start for oral diet, and it should be given. You have to given high fiber diet, and also it will help for softening the stools. Then speech and communication pre-operatively nurses play an essential role in helping the patient and family to identify the best method of communication. We have to during the before the surgery itself, we have to identify the what are the possible methods for of communications. We have to identify and we have to teach the patient, or we have to establish the communication skill with the patient. So it will be help them after the surgery, like slate method or any writing board method, paper and pen method. These all things we have to teach them. Magic slates, writing materials, pictorial guides, or hand signals are useful ways for the new laryngectomy patient to communicate. So these are the things which we can help them for speech and communication, that we have to teach them in the pre-operative state. Then the three major methods of speech post laryngectomy are, so if they are having difficulty in speech, then there are three methods are there: esophageal speech, then speech with the use of an artificial larynx, and tracheoesophageal plunger. So these are the three methods that we will discuss now. Esophageal speech is a technique that requires the client to swallow and hold air in the upper esophagus. By controlling the flow of air, the client can pronounce as many as 6 to 10 words before stopping to swallow more air. The voice is deep, but it is odd and effective once the technique is mastered. So it is a technique which you have to learn or in during the or after the post-operative stage. And it will, for this purpose, occupational therapist will help for this esophageal speech. So it is a technique where the client is taking a swallowing and hold air in the upper esophagus. They are taking the air and holding in the upper esophagus, and they are just leaving the air. So when they are leaving the air, they can produce 6 to 10 words. Okay, so a proper practice is needed for this one. And the voice is deep and it is audible and effective once the technique is mastered. Once they are practiced well, then it is very helpful for communicating. Then artificial larynx. An artificial larynx may be used as early as 3 to 4 days after surgery. This battery operated speech device are held alongside the neck or can be adapted with a plastic tube that is inserted in the mouth. The air inside the mouth is vibrated and the client articulates as usual. The speech quality is monotone and mechanical sounding but intelligible. So you can see in a device in this speech in this slide. So with the help of device, that device we are keeping on the neck area, and we are trying to speak that time. The air inside the mouth will be trapped, and it will help for vibrating the client, and it will help for producing sound. So it is also a technique which help for improving speech. Then tracheoesophageal puncture (TEP). It is a surgical technique that also restores speech. A small puncture is made into the upper tracheostoma to the cervical esophagus for creation of a fistula. After the fistula tract has healed, a small one-way valve or voice prosthesis is inserted. So it is also a technique which is a speeching approach, which is a surgical technique which help for restoring speech. In this procedure, a small puncture is made into the upper tracheostoma. So just above the tracheostoma, we are making a small puncture that is towards the cervical esophagus or towards the esophagus, upper esophagus. And after the fistula tract has healed, so once the opening is healed, a small one-way valve or voice prosthesis is inserted. So we are inserting a one-way valve or processes, so one side air entry will be there, so it will help for producing the sound. By occlusion of the process, air can be shunted into the esophagus and used to produce speech. So once the air is enter inside the valve, it is inside the processes, the valve is closed, and that air we can use for producing sound. The TEP may be done concurrently with a total laryngectomy or as secondary procedure after healing and radiation therapy. So it is mainly done concurrently or along with the total laryngectomy or secondary procedure after healing and radiation therapy. This device require maintenance. Therefore, only clients who are highly motivated, who are able to perform self-care, and who have good manual dexterity are eligible for this procedure. So this particular device is needed, that process is needed maintenance. So a skilled person or those who are knowing about the technical side of the device can use this properly. So who are perform self-care or who are highly motivated or have a good manual dexterity are eligible for this procedure. So this is all about the three methods for improving the speech. So this is a method we are doing for tracheoesophageal puncture. So you can see in the second diagram, it's a enlarged diagram. You can see the devices which we are keeping in the tracheoesophageal the trauma. the tracheostoma. Okay, through the tracheostoma we can keep that particular device. It will helps to trap air inside the esophagus, and it will help for producing sound. Okay, so this all about the topic cancer of larynx. So it is a vast topic and very important for your exam. Today we are discuss about what is the definition, causes, risk factors, then what is the pathophysiology, then we have seen the clinical manifestations, how to diagnose, then four stages of laryngeal cancer, then what are the management, mainly radiation therapy, chemotherapy and surgical management, then what are the pre-operative, post-operative care, and what are the complications of laryngeal cancer, and how we can improve the speech after total laryngectomy. So these all topics we are discussed today. I hope all of you clear about the topic. Have a nice day. Thank you.